Hello, everyone. Good afternoon. Thank you, Kenneth, and hello to all the audience of the Chamber of Commerce. Special thanks to Juan Carlos Agosto, President of the Chambers, and Jose Enrique Fernandez. Honestly, as Kenneth was saying, we're in debt to Jose Enrique. It's incredible the work that you're doing, and I'm thankful to be part of it in a way in all this process. So thanks for the special effort with the quality with the with these lawsuits and all this process. So as Kenneth was mentioning, I've been working with healthcare and getting fairness for healthcare in Puerto Rico for the past 10, 15 years, going a lot to Washington, D.C., to Congress, also to CMS in Baltimore, the Department of Health and Human Services, in a topic that I think you frequently hear about healthcare as something that, it creates a lot of conflicts, challenges, push and pull among all the components. But this really has been a topic that unites all the components in the island: doctors, hospitals, health plans, and even other sectors of the economy, all concentrated in getting fairness in the healthcare programs for the island. So I'll go directly to just 4 points and to the specific programs that some of them are in the lawsuits and have been mentioned here. First of all, and this is something I think, are you seeing the slides? See, they're up. Okay. Uh, so first of all, I always come back to this slide. You see to your right the bar charts. This is a study that was done actually due to an effort from us, the community in Puerto Rico. We work very close with the Department of Health and Human Services at a point in time with a task force looking in detail at all the healthcare policies for the island, and they published a report. And they published numbers that we all know, but this time it was the federal government themselves publishing it. You see that in Puerto Rico, and even today, I've sort of updated some of the numbers. The per capita investment in healthcare nationally is around $11,000, and the per capita investment in healthcare in Puerto Rico is around $3,600. It's from 11 to $12 billion total. And when you hear about doctors leaving, when you hear about our struggles managing Hurricane Maria effects or the earthquakes, the fragility of our infrastructure, physical infrastructure in healthcare, and information technology infrastructure, it all comes back to this fact. We work with about a third of the resources in healthcare compared to the rest of the nation. We obviously pay the same. We're in the same market for prescription drugs. We have to pay the same price, and Puerto Rico is not cheaper in all the components of healthcare. The only thing that's cheaper in Puerto Rico is people, actually, professional services, and that's why you see the migration of many of our best professionals going to the U.S. So going to the cases and the specific parity components, I'll start with the Part D low income subsidy, which is specifically addressed in the Peña Martinez case. And when I was thinking about what bringing up here, I mean, there's some information already around the basics, but I lived through this process in 2013. HHS actually issued a report, like a 125-page report, that was requested by the President's Task Force on Puerto Rico back then. So HHS addressed many of the policy issues related to healthcare, and the Part D low income subsidy was one of them. You have an excerpt there, but I'll tell you in a nutshell what it is. When the Part D low income subsidy was created by the Medicare Modernization Act in 2003, Part D started 2006. As Neil, I believe, was mentioning, they established a block grant for Puerto Rico instead of the regular Part D low income subsidy. The block grant has an amount that started about $40 million total, and it goes up with inflation. It's probably around 50 something $million right now that our local administrator of Medicaid uses. If Puerto Rico were to get the regular Part D LIS program that works everywhere else in all the other jurisdictions, we estimate that there could be between 800 to $1 billion more reaching the islands to pay for prescription drugs of the elderly population, the disabled population, and most of them elderly and poor. The Part D LIS, as you see in this report, and again, many times we try to use federal sources, just to gain the credibility. So this report from HHS estimated back then in 2013 that around 500,000 people would be eligible to the Part D low income subsidy. That means, that means a lot. Right now, only 280,000 people are actually benefiting from that $50 million, which is pretty little. Uh, and So we're saying that almost double the amount of people who actually have access to these benefits. So that's the Part D LIS. Going to Medicaid, and I'll talk about Medicaid and then Medicare Advantage, trying to portray sort of the highlights of what parity means. Going to Medicaid, this chart that I'm presenting now is from the GAO, the same organization that Jose Enrique was referring to. They in one of their articles they presented this basically a summary of what are the benefits, mandatory Medicaid benefits that in Puerto Rico are not covered, which would be, again, as a result of the lawsuits, uh, this would have to be addressed, in my view, because this is also part of the benefits. And if you are you're a U.S. citizen, you reside anywhere in the states, you would be eligible to these benefits, and you will be able to access all these mandatory benefits. And you move to Puerto Rico and you lose that access. If you see the red arrow, I'm pointing particularly to what's called home health and long-term care, nursing homes. In the US, just to give you an interesting fact, Medicaid spends around $150 billion in long-term services and supports as a mandatory Medicaid benefit. In Puerto Rico, the spends on that benefit is zero. There's nothing. It's completely excluded of the Medicaid program because there's no funding for it. You have also other items like non-emergency transportation and other benefits that are certainly needed, but are not as big as this one. And in this slide, I show you a little bit more of that. The dual eligible, the elderly and poor, people that are eligible to Medicaid and also eligible to Medicare, they're mostly covered in Puerto Rico through the Medicare Platino program, which is an integrated program. In the States, a person that is dual, about 46% of the resources that pay for their healthcare come from Medicaid. In Puerto Rico, it's less than 1%. The government of Puerto Rico has only been able to pay the plans $10 a month for the care of the elderly and poor. So basically, the care is almost 100% being given through Medicare Advantage and Part D, with almost no help from Medicaid. Whereas if you move to any state, or if the citizens would have access to the same benefits as the states, you would have all the Medicaid resources paying for things like long-term services and supports, paying for things that the Part B member premium, and other benefits that are covered elsewhere. The Part B member premium, for example, right now it's $144 per month. That's taken away of our poorest elderly and disabled population from their Social Security checks mandatorily in order for them to have Medicare AB and get into Medicare Advantage. If you are able to cover that, like it's covered elsewhere through Medicaid, that means that's like $400 to $500 million in the pockets, in the checks of our beneficiaries, that they would have a disposable income that they can spend in our economy, as it has been referenced here. So lastly, I'll mention the case of Medicare Advantage. We've talked about this as well in the past several years many times. Medicare Advantage covers over 600,000 people in Puerto Rico right now. As I mentioned, 280,000 poor beneficiaries under 85% federal poverty level. And it's actually the most structured program in the island. And you can see the companies competing, all offering more benefits to beneficiaries. But again, we fall very short. If you see that that green line with the Affordable Care Act, there were cuts that were over 20% between 2012 and 2017. And then we've been going to DC, as I mentioned, for 10 years. We've been getting little fixes in Part A. For example, there was a wage index floor just established. In Part B, we were able to change what's called the GIPSI, the practice index, for Puerto Rico. And many technical items that we've been working to, just taking little steps, to bring that number to 588. But the big, the most revealing thing here is that the 588, it's still 40% below the national average, which is the 982, and it's still 22% below what a citizen would have in terms of the resources paid for Medicare Advantage in the U.S. Virgin Islands. So this is all a construct. Medicaid and Medicare fragmented payments or discounted payments started since the get-go, since the 1960s. And this is the result of it. So again, we would hope that the momentum and the results of these lawsuits that are based on fairness would actually have a direct result in all these numbers, bring us closer to the economy of healthcare that works in the States. Even if we make that process, I am convinced, we're convinced that Puerto Rico can provide the most cost-effective healthcare around the nation. It's not about that. It's about being at the bottom, at such a distance that it disrupts our healthcare, it creates access problem, and it doesn't let us move forward. So we're counting on a big effort. It needs to be all together. And again, thanks to the chamber, thanks to Jose Enrique. I think we're all behind those lawsuits, and we hope to continue moving forward. I'll leave it there.